So I'm Colleen Makarowski. I'm a respiratory therapist, and I'm also a Certified Respiratory Educator, which just means I've taken some additional training to become a respiratory educator here in Canada. And I also have my Certified Tobacco Educator certificate as well. As an educator, ask them the questions and also allow them to kind of give me some information back. So it's kind of a guide on the side in information giving, sharing that maybe family physicians or lung specialists don't have the time to do or to spend with the patients in that way. So there are some respiratory educators that work directly with lung specialists in the major centers, Edmonton, Calgary, Red Deer as well. And there's other healthcare professionals that have the designation. So you can look towards pharmacy would be my next person to look at, because there are numerous pharmacists across Alberta that have that designation in that piece as well. So in this image, it does show two differences, one side versus the other, one that has a nice healthy look to it and one that has been diagnosed with COPD. So the changes that we start with are to the airway. A lot of people will think of COPD as emphysema, chronic bronchitis, or even label it as asthma. So I like to really dive in a little bit deeper to show the difference. Again, nice healthy airway should have nice pink inside and bands of muscle relaxed. When we have COPD, that airway has more of a chronic swelling or inflammation that happens to it. So the lining of that airway kind of stays very red and a little bit more angry looking, can have a bit of swelling, but also that can be where that mucus production comes from. So when patients ask about why do I cough so much, why do I have some stuff there, it is really coming from that airway. Bands of muscle can have some tightness to it, again, depending on what you're doing. Sometimes when you're quiet, it might not be quite as impact, but it is important to know that the airway does have a piece of the puzzle. The next difference is the actual air sacs. So again, when we take a big breath in, nose and mouth, and it goes down into our right and our left lung, air is going to travel all the way down these airways, and at the end of the airways, we have all these little air sacs that fill up with air and move our oxygen and carbon dioxide around. So we've got lots of air sacs in our lungs, both sides, and so that's what makes our lungs kind of spongy. And so good news is that we've got lots of them, but when you've been diagnosed with COPD, it does mean that some of these air sacs, the walls of the air sacs, are breaking down. And so as they break down, that can't be repaired. And why that's important is because when these little air sacs break down, that's where air kind of gets stuck and trapped. And when we talk about possibly that idea of overinflation or trapped air, that is linked directly to that sensation of shortness of breath. And that is a big difference between asthma and COPD. With asthma, we do not see this breakdown. So just with COPD, we start to see the breakdown. So that's a good image, and you can also see the image here. Again, a healthy lung on this side, not so healthy on this side. Other changes that you might see here is that this lung is a bit bigger in size, and that is that overinflation, that trapped air that has come from all of these little air sacs being broken down, so that your lung itself can get a little bit bigger and stay a bit more enlarged. The other difference that can happen as the disease can progress is because the lungs can be a bit bigger, you can get a restructuring of your rib cage. So you can get a bit more of ribs kind of popping out a little bit. We call it a barrel chest, and that can be from more advanced disease. And then the bottom piece here we see is the diaphragm. So our diaphragm is one of our big muscles of our airway, runs right underneath our lungs, and its job is to kind of come down when we breathe in and come up when we breathe out. So it has movement, up and down movement. And over years and years again of having COPD, that diaphragm is working extra hard. You know, that diagnosis can be a bit overwhelming. So initially we just talk about what that disease or what that label means to them to start with. So I like to get a sense of what they know about it, where they think this has come from. So just get, again, a bit of a sense of that patient and how they're actually absorbing that information. And then we talk about what it means to have COPD. So again, it is a lifestyle change, being diagnosed with a chronic illness. So I try to give them as much information directly about what this disease means. So what happens to the airways, what are the changes that happen, and we talk about then their symptoms. So I get them to tell me about their day-to-day. What does it look like to have this disease when you wake up in the morning to the time you go to bed? And so we reflect on the changes and maybe the struggles that they might have throughout the day with their breathing. Then we look at the inhalers, give information about how to use these devices correctly, and understanding maybe they have more than one inhaler, for example. So again, why do I have more than one inhaler? What does that mean? Also talk about what to do if you have a really bad flare-up. What does it look like? What have you done in the past that has worked? Maybe somebody has ended up in the emergency room or hospitalized for their lung disease, for COPD. So what was that all about? How was that managed when you came out? Is there opportunity to kind of bridge a bit of information? So if it happens again, what can I do to help them react differently? So management plans are also another piece of the puzzle for COPD in particular. This is a lifelong disease that can have different stages throughout. It certainly can be a progressive disease, so just trying to get them to understand that at any stage along the way there's things that we can do to kind of help better their quality of life. With COPD, as you can see from this chart, there's a lot of different inhalers out on the market. So really the advancement with COPD and the treatment of it has been really good in the last few years, as we've had quite a few new inhalers come out on the market. But as you can see, there are different medications that come in different forms. So they can be more of an aerosol, or they can be a powder. So because there's so many differences, it doesn't mean that one's better than the other. It's about finding the right combination of medications that work for you. And the job of these inhalers are really to help to get that muscle around the airway that I demonstrated to be very relaxed as we can, so that you have that movement of that airway to lessen that level of shortness of breath. The other thing is that it's important to know how to use these correctly. So because, you know, some open, you twist, you push a button on another one, they're very different. Good conversation to have with a respiratory educator or somebody knowledgeable about these devices. So your lung specialist may offer some support to you, your pharmacy, your pharmacist, your family physician, maybe a nurse in the PCN if your physician belongs to a primary care network in Alberta. There's a variety of different healthcare professionals who are very knowledgeable about COPD. The other part of it is the non-medication piece. So how do I learn to breathe different? Why does this impact my quality of life where I can't do things? But also give them some techniques, different breathing techniques perhaps, to better manage their shortness of breath with exertion or their stress, anxiety levels. So we talk about the non-pharmacological pieces of this puzzle as well, where it is around stress management, relaxation techniques. I might also dive into some help around smoking cessation, how to learn how to quit, and options that we might have that way. So pulmonary rehab is another piece of this puzzle, like really trying to encourage somebody with a lung disease to keep moving. Not trying to train anybody for a marathon, but just get them to understand what that means to their lung health when they keep moving, because it's very easy to just sit still. So it is normal to get short of breath. because of, again, this trapping of air. And when we get short of breath, it's very normal to get anxious about that. Your anxiety goes up, and when your anxiety goes up, you're not going to breathe as good. So then we get into a vicious circle. I'm not breathing good, my mind gets going, and you get panicked, and you can get into this very vicious circle of just more and more symptoms. So when that does happen, so again, a few things. We encourage them to understand. When they understand that that trapping happens, then it's encouraged, you need to kind of dump it a little bit better. So with a diagnosis of COPD, the odd thing about it is that we encourage people to think about their breathing and really readjust the way they breathe. So I encourage them to think about a couple of techniques. One is called pursed lip breathing. And it is about trying to deflate those lungs on their own. So when this trapped happens and we start to feel more short of breath, if we stop what we're doing and think about our breathings. So pursed lip breathing is about being very mindful about taking smaller breaths in. We have a tendency to grab air when we can't grab it. We want to grab more. And so it's not about big breaths. It's trying to tell them to try and tone that breath down a bit. Smaller breath in through the nose, and then pucker their lips like they've got a straw in their mouth and kind of blow out and make your exhale longer. So it is about small in through the nose and then pucker. So if I was to do it, just so longer out. So in through the nose, count to 2, out through the mouth, count to 4. And it just allows your body time to kind of dump some of that trapped air. And as you do that, that level of shortness of breath is going to calm down along with that. So you're not going to feel as air hungry. So that part of that is about being knowledgeable about a breathing technique, as well as body positions. How can I sit and be effective with trying to position my body to breathe a bit better? So use your other parts of your body to give some support so that your lungs can do what they need to do. So again, tripoding, we call it tripoding, where the arms are down firm, leaning in a little bit. If you can't have a table in front of you, sit up but lean on a table. So that's what these images all represent, is a way to relax the body when you feel really anxious, but also the importance to keep moving. And when you do move, to really practice really good breathing techniques to kind of keep that level of shortness of breath down. It is a disease, I think, that can create a bit of loneliness, that maybe people feel like they're all alone with it. I think there's a guilt associated with COPD, just having that maybe a smoking history. So that those pieces of the puzzle, for whatever reason, tend to make people maybe sit back a little bit and not source out the information. But it is a team effort. We're all here to support these patients, and really the opportunity is there for sure with, again, these inhalers that are out there right now, and good information about pulmonary rehab and how to treat a flare-up and what to expect out of a flare-up and those things. I think those are good information to know that we can improve and manage a really decent quality of life.